My dear students, in this video, I am going to discuss about sepsis in 2026, what's new in it, and what still matters. Some core principles remain unchanged. It is true for sepsis also. So even in 2026, the core principles which have been continuing so far that remain unchanged include: 1. Early recognition, where clinical suspicion is the key and there is no need for waiting to the scores. Early antibiotics within 1 hour of recognition. It is also another core principle which stands tall even in 2026. Initial fluid resuscitation with crystalloids as the first line and the vasopressors and the second line, and among the vasopressors, norepinephrine being the first choice to maintain a mean arterial pressure of greater than equal to 65 millimeter of mercury to entail adequate perfusion is also a core principle which does not change. The source control is very important in sepsis. If there is an abscess, it needs to be drained. If there is an infected device, it has to be removed. And this often is the definitive treatment, and all other treatments are secondary. So, source control is also another core principle that is unchanged. And finally, monitoring lactate, monitoring urine output, and monitoring the clinical performance of the patient through repeated clinical examinations in a time bound manner are unchanged, and the important doctrines that has been followed and continue to be followed. Then what's new? The new important change in sepsis is the understanding the concept. No longer sepsis is recognized just as an inflammation or an just an immunological reaction. It has a immunological basis, but the understanding of sepsis as of today evolves around understanding it as an immunometabolic disease, which is driven by immune dysregulation, metabolic reprogramming, and mitochondrial dysfunction. Now, this finally culminates into classifying sepsis into certain endotypes and then deriving the precision based medicine. So, the endotypes, the patients are classified into hyperinflammatory and immunosuppressed. The other new thing that is that has appeared this year is the AI and early detection. It is known for long that early detection of sepsis can save lives. Early recognition will lead to early initiation of treatment, and early initiation of treatment is the most important factor in saving the patient. And knowing that AI models can detect sepsis hours before clinical onset, integrating such AI tools to give EMR alerts and ICU monitoring systems has been one core area which is new. The biomarkers and multi-omics beyond the traditional markers of CRP and procalcitonin in the form of transcriptomics and metabolomics are also important, and they have been gaining more and more importance with time. I'm coming into that shortly. Then the microcirculation focused resuscitation is another aspect which can be considered as new, although it was detected much long back, but still for years there was a continued focus on the BP only targets with the mean pressure, and gradually there has been shift from this macro parameters or the BP only targets to tissue for perfusion in the form of capillary refill time and microcirculation. The fluid strategy has evolved in a lot more ways than one, and still some time back, what was considered as uniform a gospel of 30 mils per kg for all leads to be unsettled now as we go for more individualized and dynamic fluid therapy. One important aspect which is new is the essential emergency and critical care in sepsis, which focuses on low cost and high impact care, which is especially relevant in India and many other low middle income countries. I'm coming to that also in a short while. The post sepsis recognition syndrome has gained a lot of attention, and it has got attention because not only because it is important, but it is very common. And long term impact of this syndrome, which can cause cognitive, physical, and physiological, psychological impairment, is tremendous. Therefore, survivorship is now part of care, and sepsis does not end, or the treatment of sepsis does not end just with discharge of the patient from the hospital. Let us start a case scenario to explain the different endotypes of sepsis. A 45-year-old male presents with fever for 2 days, breathlessness for 12 hours, altered sensorium for a day. On examination, his vitals look like this: but blood pressure of 86 by 50 millimeter, heart rate of 130 per minute, respiratory rate of 32, and a saturation of 88% on room air. The labs reveal a lactate of 5 millimoles per liter, the WBC is 22,000, and creatinine is 1.8. So, the suspected diagnosis that is made in this patient is septic shock, most likely following pneumonia. Now, some clinical questions, if asked, can make the recognition of the endotype clear and the understanding of the current concepts easier based on these questions. So let us ask these questions as: why is lactate elevated? And is it purely due to tissue hypoxia, or there are certain other factors too? Why is the patient hypotensive despite no major fluid loss? And what is driving this rapid deterioration? Earlier, had it been 10, 15 years back, the answers would have been pretty straightforward and simple. But now, with the immunometabolic basis being coming into foray, a little bit of detailed explanation is necessary. In all cases of sepsis, whenever there is a pathogen, there are two patterns: the PAMP and the DAMP. These are acronyms. PAMP means pathology associated molecular pattern, and DAMP is damage associated molecular pattern. Now, since this follows an infection, the PAMP recognition leads to TLR, that is the toll like receptor activation. And this toll like receptor activation are inherently and intrinsically associated with the functioning of the immune cells, particularly the macrophages and the neutrophils. And these cells undergo a metabolic shift to aerobic glycolysis, which is also called the Warburg effect. Warburg effect is something peculiar to cancer cells, whereas the cells choose to go into the glycolysis even though the oxygen is available. Normally, we know when oxygen is unavailable, the cells choose the alternate pathway, that is the glycolysis pathway. But according to Warburg effect, as we see in cancer, the same phenomenon applies to sepsis, where despite oxygen being present, the cells choose glycolytic pathway, and because they generate ATP through the glycolytic pathway, which is very less, because there are 36 ATPs generated in the Krebs cycle, whereas only 2 ATP is generated by the glycolysis. But this is a very fast process. So, in this process, it leads to a rapid rise of lactate. And because of this lactate, and because of this ATP generation, there is a lot of biosynthetic support for inflammation, because that energy which is derived from the ATP burning of the ATP is used to gather all the inflammatory mediators, and this is the one response which we used to call earlier as inflammation, but we used not know that what is causing the inflammation. Now, this causes a cytokine surge with a rise of TNF alpha, IL-1, IL-6, nitric oxide increase leading to vasodilatation, endothelial injury leading to capillary leak, and coagulation activation leading to the formation of microthrombi, and therefore culminates into a process where there is hypotension, where there is tissue edema, as well as organ dysfunction. So lactate is reinterpreted today in 2026. It is not just a marker of hypoxia, it is also a marker of increased glycolysis. It is also a marker of adrenergic stress. It is also a marker of mitochondrial dysfunction. So the clinical implication of this is that high lactate would not always mean low oxygen delivery. So the learning point is that early sepsis is a hypermetabolic state where glycolysis drives the inflammation and the lactate is raised, which both is a indicates as a marker of severity and as a marker of metabolic shift. Coming to second case is a 65-year-old ICU patient on day 10 of sepsis who initially improved but now develops new fever with increased ventilator requirement. The labs reveal a lymphocyte count of going down and the procalcitonin is 2.8. The clinical questions that needs to be asked in this setting and explained on the basis of our understanding of the immunometabolic nature of sepsis is that why secondary infections persist despite treatment, why persistent weakness and poor recovery, and is inflammation still the main problem? So, if we again consider immunometabolic dysfunction, we find that this is the phase of sepsis where there is mitochondrial injury. And because of mitochondrial injury, there is fall in the oxidative phosphorylation, which is normally the key step in aerobic metabolism. And alongside, there is also a fall in ATP production. So the immune cells shift to the hypometabolic state and thereby leads to reduced immune function and energy failure. So this is characterized by T cell exhaustion, monocyte dysfunction, and lymphocyte apoptosis. The final consequences of this process being poor antigen presentation and reduced pathogen clearance. So this reduced pathogen clearance cannot be circumvented unless and until the true approach to this respite is obtained from this immunometabolic dysfunction. So, the clinical manifestations in these patients would be secondary infections in the form of VAB, fungal infections, etc., viral reactivation like CMV and herpes, ICU acquired weakness, and prolonged ICU stay. So, the learning point from this second case is that immune exhaustion and energy failure can also be seen in such patients. Mitochondrial dysfunction is the central, and mortality is often high and is usually due to secondary infections. Let's come to case 3 now, where a 58-year-old female with septic shock has persistent fever, hypotension, lymphopenia, and recurrent infections. Here you can see that this patient has both hypotension and persistent fever, mm, which points towards the hyperinflammatory stage, whereas the lymphopenia and the recurrent infections points towards the immunosuppressed phase. So the clinical question is, can both inflammation and suppression coexist in a patient? And if it is so, how does this affect the treatment decisions? So, if you go by the literature, the studies have always highlighted that sepsis is not biphasic, it is simultaneous, which means that hyperinflammation and immune paralysis can occur together due to immunometabolic dysregulation. So, there is a scope for mechanistic integration, that is, different immune cells behave differently. Neutrophils can be hyperactive, T cells suppressed, metabolic mismatch being glycolysis is increased in some cells, mitochondrial failure observed in the other cells. So, this has a lot of therapeutic implications because one size fits all therapy fails here, and the future approach is to combine both hyperinflammatory and immunosuppressed therapies in such patients. Examples include IL-6 blockade, which is with research, IL-7 and GM-CSF. So this points also to the fact that sepsis is a heterogeneous syndrome. It does not refer to any disease in particular, and that treatment must be individualized and driven by biology. So the entire sequence, starting from infection to immune activation to metabolic reprogramming, followed by hyperinflammation plus immune paralysis, then leading to circulatory failure and organ dysfunction, is essentially the steps, but it is not clear as to how much time is required at each of these steps. Biomarkers are a new gadget or the new armamentarium because their numbers are compounded, as I told. Some of these biomarkers are host response biomarkers because they assess how the patient responds. They do not find out how the infection is present or not. And such host response biomarkers include IL-6, TNF alpha, and IL-1 beta, and presepsin. The advantages of these host response biomarkers is that they can detect sepsis earlier than the PCT or the CRP. Next, coming to the transcriptomics or the gene expression potentials, which many of you know that this measures the gene expression pattern of the immune cells. For example, septicite lab or rapid lab differentiates sepsis from non-infectious inflammation by use of transcriptomics. Gene signatures are able to identify hyperinflammatory versus immunosuppressed states. Then clinical value, endotype classification, and precision medicine. Then comes the metabolomics biomarkers. Now, these metabolomics biomarkers reflect cellular metabolism and energy failure. The key markers include lactate, succinate, itaconate, and acyl carnitine. So, acyl carnitine indicates mitochondrial dysfunction, whereas succinate is a pro-inflammatory metabolite, and itaconazole or itaconate is an anti-inflammatory regulator. Then there are the immune function biomarkers because they are used to detect immune paralysis. The key markers being monocyte HLA-DR expression, absolute lymphocyte count, and PD-1 or PDL-1 expression, particularly as a marker of T cell exhaustion. So the clinical use that identifying patients needing immunostimulation is possible in those patients who are having low immune function biomarkers, and likewise, there are certain new therapies coming up, that is the mitochondrial activator. So if that therapy becomes practiced, then probably metabolomics biomarkers will aid in their use, especially in those patients where there is high cellular metabolism and energy failure. Among the newer biomarkers also are the endothelial and microcirculation biomarkers, which reflects the vascular injury. For example, angiopoietin 2, syndecan 1, VEGF, that is growth factor, and predict capillary leak and organ failure. Then comes the biomarker panels by plus AI integration which is the future direction. And in this case, it is good to combine all, that is cytokines, gene expression, and metabolites. So AI-driven sepsis prediction models are the typical example for newer biomarkers, but the advantages are to be remembered: early detection, risk stratification, and personalized therapy. So, why microcirculation focused resuscitation target still has relevance? We have seen that the Andromeda shock trial compares CRT guided versus lactate guided resuscitation, and according to their findings, we can see that the CRT guided strategy produces faster resuscitation, less fluid overload, with a trend which is better towards survival. So the old novel or the old aim of fixed 30 mils per kg for all has been challenged, and this has also changed because when we know the microcirculation and we adopt to microcirculation guided fluids, then it is easier to be connected. So you have to give fluids if CRT is prolonged, and and signs of, and whenever there the perfusion is low, we can give fluids And whenever the perfusion improves and there is a risk of overload, there it can stop. In terms of AI and early detection in sepsis, we need to understand what does AI actually do. AI models, they analyze large volumes of real-time data where inputs are provided by the vital signs and the lab data, and the clinical notes are based on NLP based models. The trends over time, output, sepsis, risk score, and early warning alerts are all important AI tools that are being used, although data is not available about their best benefits. So, how can early AI detect sepsis early? AI can detect sepsis early, that because can detect it 4 to 12 hours before clinical recognition. And the clinical impact of this is huge because the patient gets early antibiotics, faster resuscitation, and potential mortality reduction. So, how AI fits into the clinical workflow of an ICU physician? It is because it provides scope for continuous data monitoring, risk score generation, alert to clinician, clinical validation, and early intervention. So the common AI-based systems include the machine learning models of random forest gradient boosting and neural networks. The clinical example or typical is epic sepsis model, that is the ESM, and the insight algorithm. There is one more called the TRUES, which is targeted real-time early warning system. So the advantages of applying AI is that it can cause earlier detection than clinical judgment, continuous monitoring like 24 into 7 vigilance, and continue integrating multiple variables simultaneously, and thereby it can reduce ICU admissions, and not only admissions, it can be reduce mortality too. But there are certain limitations of AI too, which one should note and apply it in mind while interpreting the results of AI. False positives are the cannot be said, and their causes alert fatigue, poor generalizability across hospitals, data quality is dependent. The black box models suggest lack of interpretability. And one example at the epic sepsis model, which showed a low sensitivity in external validation. Regarding essential emergency and critical care, which is a set of life saving, low cost, and universally acceptable interventions that should be provided to all critically ill patients, regardless of the setting, that whether it is an ICU ward, emergency room, or low resource environments. And if we compare essential emergency and critical care to advanced ICU care, we can see the differences. The focus for ECC is basic life-saving care, while that by advanced ICU care is for organ support. Again, the tools used in ECC include are included, and it is a simple, low cost with all healthcare workers, and it prevents early death. On the contrary, in advanced ICU care, we have organ support. So facilities for organ retrieval also makes a difference. They have high tech ventilators and ECMO, presence of specialists, and they are able to manage complex physiology. So most deaths occur due to failure of basic care. They do not occur due to lack of advanced care. And this is the reason why essential emergency and critical care, that is the EEC, requires ensures that no patient die from preventable causes. Post-sepsis syndrome is a very important aspect of sepsis care in 2026. And this is important because it needs to be recognized, and it is often not recognized, ultimately leading to complications. So over 30 to 70% of the survivors are affected with post-sepsis syndrome, which is and the major cause, which is the major cause of readmission, poor quality of life, and late mortality. So when should we suspect post-sepsis syndrome? It should be suspected weeks to months after discharge. There are certain red flags which one need to exert caution about, which include persistent fatigue, poor functional recovery, recurrent infections, and cognitive decline. This post-sepsis syndrome has certain clinical domains, which include the physical domain. The physical domain includes ICU-acquired weakness, sarcopenia, reduced exercise tolerance, etc. The cognitive domain includes memory impairment, poor attention, executive dysfunction, sepsis-associated encephalopathy sequel, etc. The psychological includes depression, anxiety, and PTSD. And the immune dysfunction, which is characterized by persistent immunosuppression, secondary infections, and viral reactivation, is also important. So, there are certain bedside tools for diagnosing post sepsis syndrome or recognition, that these are based on functional status, the adjusted daily living, that is they can decline, and also 6-minute walk test. The cognitive screening is achieved by MMSE or MOCA, as and when the situation may be, and psychological screening for depression and anxiety by the help of biomarkers PHQ-9 and GAD-7. This has been done. So, the management principles of post sepsis syndrome would be physical rehab. One is which includes early mobilization, structured physiotherapy. Again, they also requires cognitive care in the form of screening plus rehabilitation. Mental health requires CBT, medications if needed, uh, immune support, and also one should look for vaccination and infection surveillance. So, to achieve that, we need follow up clinics in the ICUs, and in our hospital also, we have started the online critical care follow up clinic. So, finally, when we look into these changes and also we look into those which were there since long, so what we can understand is what has changed versus what hasn't changed. So, the definition which was earlier SIRS based, that it became later into organ dysfunction based, applying SOFA. The view of the disease was purely inflammation, and the view of the disease is immunometabolic as per as per the current status of sepsis. Treatment is protocolized in the old approach but personalized in the new approach. Fluids should be administered liberally according to the old approach, but microcirculation, it is there in here also. So 2026 approach includes that, and and the survivorship becomes more important than survival. So the key take home messages would be sepsis is organ dysfunction plus minus infection. So the SOFA score has to be more than equal to 2. Early antibiotics save lives, though if they are administered within an hour. And there has been shift from protocol to personalization. And fluids should be given early but avoided overload. The sepsis is heterogeneous, future is precision medicine, and AI is promising but not yet definitive. Thank you.